Hi, doctors. Very good evening. I'm Dr. Arvind here. I'm the lead medical for Roche. I'll cordially invite you all for this Best of ASH CME sponsored by Roche. Actually, 63rd ASH annual meeting and exposition has happened on December 11 to 14 at Georgia World Congress Center, Atlanta. And for this CME, we have handpicked a few of the topics to be brainstormed in today's CME. And to begin with, let me welcome and introduce the program director and moderator for this event, Dr. Sharath Damodar. Dr. Sharath is a senior consultant hematologist and head of hematology and bone marrow transplant, clinical director, MSMC, vice chairman, NH Oncology Collegium, Majumdar Shaw Medical Center, Narayan Health City, Bangalore. Welcome, Dr. Sharath, and the stage is all yours. Thank you.
Thank you. We're all set to start off this ASH update, and it's a pleasure for me to introduce the first speaker, who's Dr. Hari Menon, who will be talking to us on the recent updates in follicular lymphoma. Dr. Hari is currently Professor of Hematology and Medical Oncology and Head Department Medical Oncology at St. John's National Academy of Health Sciences Medical College Hospital. He's been the ex-professor in medical oncology at Tata Memorial and subsequently head of the Department of Medical Oncology at SiteCare Hospitals, Bangalore. He's also a good friend of ours. Dr. Hari, all yours.
Thank you, Sharath. I'll just share my my screen. 1 minute. Yeah. So. Oh shucks, what is happening? I'm sorry, there's some. Can you hear me? Hello?
Yes, Hari, you're back.
Yeah, so it just went off. I'm sorry about that.
Yeah, no problem.
Yeah, so I'll just share my screen. So is my screen visible? Yes?
Yes, Hari.
Yeah, thank you. Sorry for that. I got logged out in between.
Yeah.
So the topic of today's discussion that has been allocated to me is on follicular lymphomas, and given a special emphasis on what are the recent updates at ASH 2021. So before I just begin, let us mine is not progressing. Yes. So follicular lymphomas, as we know, is the second most common form of NHL, and it's estimated that about 13,960 new cases are found in the US. That was recorded in the SEER data of 2016. And despite most patients presenting with asymptomatic lymphadenopathy, majority are diagnosed with disseminated disease, almost 80%. And we know that in general, they have an indolent course. We can afford to keep them under observation, and some of them requiring systemic chemoimmunotherapy. The proportion relapse most certainly, and we do understand that even though we can call it as a functional cure, we rarely encounter real cure in follicular lymphomas, and about 2% have a tendency to transform into a high-grade lymphoma. And with the advent of chemoimmunotherapy and newer drugs that have been used, especially with the advent of bendamustine in combination with chemotherapy, the bendamustine in combination with immunotherapy, the the landscape has changed, and as is clearly reflected in these graphs, there has been a clear improvement in the last 5 decades. And with the emerging role or a confirmed role of using even maintenance immunotherapy or monoclonal antibodies like rituximab, there has been an improvement in the progression-free survival of these patients. But we need to be judicious about which is a backbone where you will implement maintenance therapy. But there has definitely been an improvement. And we all have always understood that follicular lymphoma is an entity that is amenable to certain immune modulations and immunotherapies too. So we also recognize that there is always the rule of 24 that we always look at in follicular lymphoma. So if you can get a follicular lymphoma to be in remission for the first 2 years of the treatment, then the chances that they will relapse are less frequent. But as is reflected in this graph, the role of early relapse and the outcomes for early relapses are far, far more inferior as against a patient who may relapse much later after a primary treatment. Similarly, if you have a PET scan positivity following primary treatment, there is a greater chance for them to relapse, as is reflected in the Kaplan-Meier curves on the right side. So when we talk about management of primary follicular lymphomas, it's very clear how we not do, and it is the standard treatment of going through with chemoimmunotherapy plus minus maintenance treatment in these patients. But what about management of relapsed refractory follicular lymphomas? We know besides giving chemoimmunotherapy in these patients as a rechallenge, depending upon how soon the patient has relapsed, we also know that newer anti-CD38 antibody like obinutuzumab in combination chemotherapy have shown, as is shown in the GADOLIN study, an improvement in their survival in terms of an improvement even in overall survival in these patients when using newer monoclonal antibodies. Similarly, using immunomodulatory drugs such as lenalidomide, as was demonstrated in the AUGMENT study, clearly demonstrated an improvement in progression-free survival and overall survival in the relapsed refractory setting, thereby allowing for a combination of lenalidomide with rituximab as a standard of care in patients with relapsed refractory follicular lymphomas. Tazemetostat is another drug which is the EZH2 inhibitor, and we know that EZH2 mutated follicular lymphomas do have a relatively better prognosis, and using this inhibitor have shown responses in these patients, but though it has not really been that popular in the treatment of relapsed refractory myeloma, and still not considered one of the lines of treatment that one would adopt. The ZUMA study, which was looking at CAR T cells as we would prove for any lymphomas, was the first phase 2 study which looked at follicular lymphomas in the relapsed refractory setting. And that also clearly showed an improvement in terms of responses, and the key secondary endpoints of CR rates, overall response rates, duration of response, progression-free survival, were all achieved, and giving us a signal that in the phase 2 study that CAR T cells do work in follicular lymphomas in the relapsed refractory setting. So what did ASH 2021 have in terms of newer therapies or newer or long-term outcomes for these modalities of treatment in the relapsed refractory setting? So the first study that came to mind was the use of bispecific T-cell engagers, which is mosunetuzumab monotherapy, which was an effective and well-tolerated treatment option for patients with relapsed refractory follicular lymphomas, as was evidenced in this phase 1/2 study. So mosunetuzumab is a CD20 by CD3 bispecific antibody that engages and redirects T cells to target the malignant B cells. And the result of the phase 1 study showed promising efficacy and manageable toxicity. And so they went on to the phase 2 study, and the current analysis were reports from the phase 2 study that was presented at ASH 2021. So basically, the study was that basically patients with relapsed refractory myeloma grade 1 to 3A who had received more than 2 prior systemic therapies were included in the study. The first, the protocol meant that we used mosunetuzumab on day 1, day 8, and day 15 in a gradually escalating dose of 1 milligram, 2 milligram, and straight away going into 60 milligrams. And the second dose was at 60 milligram, and the subsequent doses, which was up to 8 cycles, was given at 30 milligram. And this was a single-arm pivotal stage phase 2 study with a primary endpoint of CR rates and investigator assessed outcomes, and also secondary endpoints of overall response rates. So what came out is that there were about 90 patients enrolled into this phase 2 study, single-arm study, and the median age was 60, and they had majority of the patients, 70%, were in stage 3 and stage 4 disease, and there were a good proportion of patients who had received more than 4 lines, and even those with 5 lines of therapy in this subset. And almost all of them had received, as would be expected, anti-CD20 therapy. They had received alkylators. Some of them had received PI3 kinase inhibitors, lenalidomide, about 14%, and there were a small proportion of 3 patients who received CAR T-cell therapy also in these patients. So basically, when we looked at 3 lines plus relapsed refractory, the overall response rates was a healthy 79% in these patients. And when we looked at the 2 prior therapies, again, it was not too far behind. You would have expected that patients who had more lines of therapy would do inferiorly, but that was not what the case was over here, wherein the overall response rate was matched irrespective of how many lines of therapy that the patient received prior to receiving mosunetuzumab. So the safety summary was thus that any adverse events, of course, you did have some degree of cytokine release syndrome in these patients, but they were about to the tune of mosunetuzumab related was approximately about 70 in about 63 patients. And when we look at adverse events, neutropenia was in about 30% of the patients, and largely well tolerated. And though CRS was present, it was never very significant, requiring very short hospitalization. So this is what the CRS events we have to talk about. Grade 4 was very rare. Grade 3 also was very rare. Most of them were confined to grade 1 and grade 2. And most of the CRS events were experienced in cycle 1 at a dose of 60 milligrams per meter square, and not so much in the subsequent cycles. So in conclusion, mosunetuzumab resulted in CR rates of almost 60% and an overall response rate of 80%. And mind you, this is in patients who have received more than two lines of therapy, some of them even more than 5 lines of therapy. So the fixed duration treatment approach demonstrated a deep and durable response in these patients, and they had a very manageable safety profile. So we have an off-the-shelf kind of treatment protocol for relapsed refractory myeloma, and very promising in terms of the response rates. To have a CR rate of 60% in these subset is truly impressive. So the next thing that we looked again was a subset and subgroup analysis of the LRS study, which was again the use of CAR T-cell cellular therapy for patients with relapsed refractory follicular lymphoma. And this was actually the extended follow-up that was presented at ASH 2021, wherein patients were subjected to the CD19 CAR, which is dasagenlecleucel, for high-risk follicular lymphoma. And when we said high-risk follicular lymphoma, they were mainly patients who had relapsed within the first 1 year or 2 years of therapy, and patients who had a very high SUV values on their PET scans, which suggested by criteria more high grade, a chance to relapse more often than not, as against the other follicular lymphoma. So dasagenlecleucel, an anti-CD19 CAR T cells, was approved for younger patients with relapsed refractory ALL and also in relapsed refractory DLBCL. And since the target was there, even in these follicular lymphomas, the phase 2 LRS study explored the utility of tisagenlecleucel in follicular lymphomas, and the current analysis was an extended follow-up report. So this was a treatment schema for patients: screening, FRSs, tisagenlecleucel manufacturing, restaging, lymphodepletion, infusion, and then post-treatment follow-up. So more than 5 lines of treatment, the patients were almost 28.7%, high FLIPI score in 60%, prior hematopoietic stem cell transplant in almost 37% of the patients, and bulky diseases encountered in about 64% of the patient. And when we looked at the subgroup analysis in this high-risk subset of patients, what is impressive was that irrespective of whether they received more than 5 lines or less than 5 lines, as is true with the mosunetuzumab study, there was of course, a better outcome for less than 5 lines as against about close to 60% for greater than 5 lines of therapy. But this did not translate into a longer, a relapse on the long run. So those patients who achieved CR with tisagenlecleucel continue to maintain the responses even at the 12-month survival, which is reflected in the more or less comparable progression-free survival in these patients. And what was impressive to me was that patients who, irrespective of their number of lines of therapy, except for those who received more than 5 lines of therapy, they were the cumulative response rates were more or less the same. The overall responses were almost ditto, and also the 12-month progression-free survival were equivalent. More importantly, also the progression-free survival at 24 months was similar, more or less similar, though lesser for the high-risk group, but it was sort of comparable in terms of outcomes in these patients when we were using CAR T-cell therapy in these high-risk subsets, which were otherwise having a dismal prognosis. Similarly, the SUV values, or what we call the tumor volume in these patients and uptakes, also which predicted for poor outcomes, irrespective of what they were, they also had comparable outcomes. So what the LRS study was demonstrating was a very high response rates, a durability of the response with tisagenlecleucel, with an overall response of 86%, and a 12-month progression-free survival of 67%. Very impressive. Acceptable safety profile for tisagenlecleucel was consistent with previous data. The 12-month progression-free survival for those with progressive disease at 24 months was almost, who had progressive disease at 24 months was 60%, which means they were a high-risk subset who had progressed within 2 years of a primary treatment. And the progression-free survival, even in when you had a high activity in terms of the tumor volume, was as good as about 55%. So the investigators concluded that positive results from this trial support the use of tisagenlecleucel, particularly in relapsed refractory follicular lymphomas. And just before I conclude, just a touch on the data on the PI3 kinase inhibitor, which is parsaclisib, in patients with relapsed refractory follicular lymphoma. Basically, it's a PI3 kinase inhibitor, and it is potent, highly selective, next generation PI3 kinase inhibitor used in relapsed refractory myeloma. The problems with PI3 kinase inhibitors has always been the GI toxicity, but parsaclisib was low on this with reasonably good outcomes in the relapsed refractory setting who had failed more than 2 lines of therapies. So there may be a role for this coming back into the armamentarium and one of the treatment options in relapsed refractory myeloma. Similarly, I would just allude to one more drug, which is just like mosunetuzumab, which is glofitamab, which was used. It's again a bispecific T-cell engager, which was used in treatment for follicular lymphoma, similar to mosunetuzumab. But over here, they used it in combination with obinutuzumab, and they demonstrated 100% response rates in these patients and to the tune of about 80% response rates when used independently. Thereby, there is a role for, this is one of the studies where glofitamab in combination with obinutuzumab showed better results in patients with relapsed refractory myeloma. So these were the four major kind of ASH updates in 2021. And with that, I will conclude. I'm happy to take any questions. Thank you.
Thank you, Hari, for a nice, crisp little update on follicular lymphoma from the ASH 2021. Any questions from the people who are on the panel here? Anybody wanting to ask a question? Hari, just a question from me. We don't have access to the bispecifics, CAR-T also just kind of some trials starting off.
Yeah.
So in a relapsed follicular lymphoma setting, what is your plan of treatment algorithm, Hari, in your practice?
Yeah, so again, I do take into consideration the how soon the patient has relapsed, and if the patient has relapsed early, then my feeling is that they are going to behave more like high-grade lymphomas. And in these patients, if they are transplant eligible and they are chemoresponsive, maybe we should consider the option of salvage chemotherapy over here, followed by the option of autologous stem cell transplant, which definitely shows about close to 15% better outcomes as against primary chemoimmunotherapy alone. Now, if there is if the patient is elderly, cannot receive chemotherapy, we may consider the option of R-squared, which is lenalidomide plus rituximab over here, or combine it with, if it is feasible to use it with obinutuzumab, where because the data is there for its use in terms of better, a trend towards better overall survival when using a different monoclonal antibody over here in the relapse refractory setting. Otherwise, and these are the two options that we have available in our setting. And but the entire thing is different when we are talking about relapses much later, in which case we might exercise the option of the same drug which we used earlier. If it is being bendamustine rituximab, maybe they will respond again to bendamustine rituximab and then see how it goes by subsequently. So these are the things that are available over here, but there's a lot of promise for the bispecific T-cell engagers, which may be more doable once it's available, but I would not hazard an estimation of the cost that might prevail over there.
Right. Thanks, Hari. Any other questions on the panel? Okay. Then right. So we'll end with this particular segment. Thank you, Hari, for that little update. We will now move on to the next talk. I'd invite Dr. Girish Palekai to chair this particular talk. Dr. Girish is consultant hemato-oncologist and BMD physician at SDM Medical College and Hospital, Dharwad. Dr. Girish.
Good evening, everybody. First of all, thanks a lot for inviting for me to chair this session. There are pretty burning topics today, and every time we discuss the newer aspects. And thanks, Dr. Menon, for the nice speech. Today, I'm inviting for the next topic is management of DLBCL. And for you have Dr. Nataraj, who is a senior consultant hematologist and hemato-oncologist in Sri Shankara Cancer Hospital and Research Center. We all know about him, and let's go to the topic now. And we'll have a discussion at the end of this. Thank
you. Good evening, everybody. Thank you for inviting me for discussing about practice-changing data, which has come up in ASH 2021 meeting. Overall, ASH 2021 was a very successful meeting with a lot of practice-changing data in every aspects of hematology. So I've been assigned to discuss about DLBCL. There are quite a lot of practice-changing data which has come up, but I will present restricted to about 4 or 5 trials which have been results which were published, and for the want of time. So one is polatuzumab vedotin in previously untreated diffuse large B-cell lymphoma. as we all know that most patients, depending on the prognostic factors, can be cured with R-CHOP, but up to 40% will have either a refractory disease or relapse. So to improve this 40%, there are a lot of trials, there are a lot of the hodgepodge has been done, starting from dose intensification and then reducing the frequency of dosing, or adding a maintenance therapy, or changing the therapy from rituximab to second generation antibody such as obinutuzumab. But nothing has been shown to be beneficial in any large scale trials. So this is a new drug, which is polatuzumab, which we all are been using based on compassionate use for relapsed refractory DLBCL, and it has shown benefit even as a single agent or as a combination with bendamustine and then rituximab. So this trial is based on depending on the data. So polatuzumab, as I told, it has shown efficacy in relapsed refractory DLBCL. So there was one phase 1b/2 trial with Pola-R-CHP in de novo DLBCL, and then about 89% of the patients in that trial had overall response, and 77% had complete response. Based on these data, the phase 3 POLARIX trial was conducted, which included 18 to 18 years of all the patients who are de novo IPI 2 to 5, and then regardless of the cell of origin or double it or triple it lymphomas. Key exclusion criteria was a transformed lymphoma or previous receipts of anthracycline agent and CNS involvement actively at the time of diagnosis. So it is 1:1 ratio, a double-blind randomized controlled trial where polatuzumab with R-CHP or polatuzumab with R-CHOP was included. Polatuzumab is not combined with vincristine because of the neurotoxicity which it can produce. And primary endpoint was progression-free survival, and secondary endpoint were event-free survival, PET-CR at the end of treatment, and then OS and other safety points. So there were 440 patients in the polatuzumab arm, and then 439 patients in the R-CHOP arm. So these were the endpoints, and then about 1,063 patients were assessed for eligibility. In that, 879 underwent randomization, 440 were assigned to receive Pola-R-CHP, and 439 received R-CHOP. In both group, 387 and 377 completed treatment, and 374 and 363 remained in follow-up. Majority, it's a very well-balanced trial. And then if you look at the median age, geographic region, ANOVA stage, or number of extranodal disease sites or bulky disease, everything matches between the people. And ECOG performance score has been also matched, and LDH is matched, IPI is matched, and median number of date of diagnosis to initiation of treatment is also matched. And as I've told, cell of origin is also matched. So efficacy. So coming to progression-free survival, I will show in this. So investigator-assessed progression-free survival was better with Pola-R-CHOP, Pola-R-CHP with about 76.7% event-free survival at 2 years and 70% with R-CHOP. The p-values were significant, and then p-value was about 0.02 between the curves, and then you can see that curves are definitely separating. But overall survival remained the same between R-CHOP or Pola-R-CHP. But there is an when it comes to adverse events, the adverse events were similar in both the groups, whether it is peripheral neuropathy, nausea, neutropenia, diarrhea, anemia, and there were no new safety signals with Pola-R-CHP when compared with R-CHOP. So overall, when Pola-R-CHP outperformed the standard R-CHOP by improving the progression-free survival. And based on this, the trial investigator concluded that this is the first trial in over last 20 years, which is showing superiority of the experimental drug over R-CHOP in an international phase 3 double-blind randomized controlled trial. There is 27% reduction in the risk of progressive disease or death, and 6.5% improvement in progression-free survival at 2 years. So probably this will become the standard of care over coming years, and then more and more data once we start using in regular clinical practice, I think more and more data will come. Though the trial was not intended to look at effect of Pola over cell of origin or double expressor or whatever, if you see, irrespective of whatever, whether it's age, sex, ECOG performance status, IPI score, Ann Arbor staging, or whatever, so Pola-R-CHP did better when analysis was done compared to R-CHOP. So overall, I think Pola-R-CHP is going to be, may become standard of care in the future. So the second data which I want to discuss was when should be the high dose methotrexate into frontline DLBCL patients for whom CNS prophylaxis is required, sort of based on the standard indications. whether we have to give it, sandwich it between 3 plus 3 in between one high dose methotrexate, or after completion of 6 R-CHOPs, whether is there any outcome difference. But it was this was a multicentric trial which included quite a lot of patients, about 1,384 patients. In that, half of them received in between, and then half of them received at the end, after the end of treatment. There was no difference whether you give in between the cycles or after the cycles. By doing interim methotrexate, high dose methotrexate, it delays the completion of treatment. And probably, I think there is some data to tell that it is not wise to delay the completion of treatment, because the dose density is what which also keeps the DLBCL cure rates at a higher rate. So overall, it has been, with this data, we can be a little bit sure that yes, we can do high dose methotrexate at the end of 6 cycles of R-CHOP in patients who are with the DLBCL with high risk patients. And whether there's a second question, whether is there any requirement of giving this high dose methotrexate at all? So this was a retrospective data for about 2,300 high risk patients. In this data, it was shown that though it was a retrospective data, so all patients, whether it was included all patients or patients who achieved CR, whether they received high dose methotrexate or no high dose methotrexate, there was no major difference. Since it is a retrospective data, we have to take it with some pinch of salt, because sometimes retrospective data are not it cannot be validated in prospective data. So, but maybe in very elderly population or very unfit population, omitting high dose methotrexate may also be a possibility based on this data. So when it comes to double-hit or triple-hit lymphomas, is there any way to improve over DA-PAC? Is it possible or not to assess? There was a trial in which venetoclax was included to DA-PAC. Basically, patients were given 600 mg daily, day 4 to 8 of cycle 1 and day 1 to 5 of subsequent cycles. It was shown that by doing that, they increased the chances of death in patients. Adding venetoclax increased the mortality without giving any advantage in either progression-free survival or overall survival. So overall, it looks like the excess treatment mortality is there when we use venetoclax with DA-PAC in patients with high double-hit or triple-hit lymphoma. As of now, standard of care still remains DA-PAC-R. So there were a lot of other data which came up with respect to CAR-T and other newer drugs, but I will just, for the want of time, I will restrict it to 3 studies. So I'll just tell a few things. One is ZUMA-7 study, in which event-free survival rate was more than 60% or higher than that of current standard of care when the CAR-T was used for primary refractory disease or patients who have relapsed and refractory. And Belinda study and Transform study also showed the similar results. The CAR-T therapy can be used earlier in lines of therapy, but maybe over the time it may become that instead of going for refractory disease, the Transform study and Belinda study included patients with second line or third line. So CAR-T therapy was third line, not the second line, third line. So maybe over the time CAR-T therapy may become second line treatment or the third line treatment before even the autologous transplant in future. Maybe that is what we are looking at. So with this few data, I would like to thank the organizers for giving me an opportunity to share some practice-changing updates. Thank you so much.
Thanks, Dr. Nataraj. Really nice topics you have chosen. Definitely, after a long time, you have a
Sorry for the interruption, sir. Sir, your voice is not clear.
Can you hear me now?
No, sir.
Hello? No.
There's some background noise from somewhere. Not
okay,
audible.
Right. Sorry. I'll change this things. Hopefully this should. Can you hear me now? Hello?
Yeah, we can hear you, Girish.
Sorry for the...
There is some background noise. Yes.
Hello?
Yeah, you can go ahead. I think the buzz is there.
Hello?
Yeah, go ahead, Girish.
Hello?
Yeah, go ahead, Girish.
Yeah, it's okay. Can you hear me a little bit?
Yes, all of us can hear you.
Yeah, okay. So yeah, I mean these are really nice topics. I mean basically this after 20 years we have got a new monoclonal antibodies which kind of are almost comparable to the rituximab, which is a standard of care. Second thing is still the big question remains about like whether how to do a CNS prophylaxis, whether it is needed or not. At least we got really quite a decent answer saying that we can delay the CNS prophylaxis with the high dose methotrexate a little bit late. And already for the double hit and triple hit lymphomas, DA-EPOCH is a really toxic treatment, and adding venetoclax is not a useful thing. So we got really something quite really good topics for the discussion. So anybody in the audience, I mean, sorry, in the panel, any questions?
So Nataraj, in that subset where you said the high dose MTX didn't make any difference, can we actually do away with that? Is
So
there
there
any
is-
such recommendation there? Because it's a little bit on, gray.
Yes, sir. There is no data they have not come to a complete recommendation, but with this data, they concluded that maybe like omitting may not make a major difference in sort of unfit patients whom you feel that giving high dose methotrexate may cause more trouble. I think based on this data, we can do that, but this is a retrospective data, sir. We have to look at the prospective results.
Right.
Dr. Nataraj, excellent talk. So if you decide not to do high dose methotrexate, then would you consider intrathecal therapy as a CNS directed therapy in so-called high risk patients?
Yes, we should. We should give intrathecal therapy. Yes.
Thank you.
All those patients who did not receive high dose methotrexate in this group, they all received intrathecal therapy. Just if you see, I am sure are you seeing the screen? If you see in the screen, all patients, whoever did not receive high dose methotrexate, they all received intrathecal therapies. Majority of them.
We can't see screen, but we believe you, Nataraj. We can only see you.
Majority of them received, yes.
So Nataraj, I was hoping polatuzumab would make a little more difference, when it was added to the RCHP, even though you did tell us the P of 0.02, right?
Yes, sir.
On the PFS, but the overall response rates were equal, right?
Yes.
6% difference is it, sir. You are in OSI.
There was,
Even
though
OS
there was no
similar.
difference in overall survival, progression-free survival was better. Maybe I think over the time we may get more answers, sir, because it's too early also, because they presented data at 24 months.
Girish, it sounds like you are in a spaceship, yeah? The sound and the sound and the look.
I think you are not pressing that card inside properly.
Don't know. I don't know. My son's computer, I don't know what's done it. Okay. right. Okay. Thank you. I mean, if you don't have any questions, we'll proceed to the next topic. Thank you.
Right. Thanks, Girish, for sharing that. We'll now go on to the next talk, changing gears from lymphoma. We'll move on to hemophilia, the practice-changing data from ASH 2021. And I will chair that. Dr. Meera V will give that talk. Dr. Meera is known to all of us. She is currently professor and head of the hematology department at BMC RI in Bangalore and has been doing a lot of work in hemophilia along with Dr. Cecil. So Dr. Meera, over to you.
Thank you, Dr. Sharath. Thank you for the opportunity. Sorry.
I think before she comes back, there's a question from Dr. Vinayak Chikodi. What is the mode of action of biospecifics? Bispecifics, sorry, not bispecifics.
I'm sorry, there was a brief lapse in the connection. Can you
Yeah,
hear
go ahead,
me?
Meera.
Yeah, am I audible now?
Yes.
Yeah.
And we can see the screen.
Yeah. Thank you for the opportunity, organizers. My talk is a shift from the rest of the topics, which was on oncology. It's on hemophilia. And this paper was presented from the Professor Malango and Claude Negrier and some of the other lead investigators in hemophilia. Just to recap, emicizumab, which is a bispecific monoclonal antibody, which bridges both activated 9 and 10, and is one of the newest non-factor therapies available in hemophilia, and it is a path-breaking product, which has totally changed the landscape of treatment in hemophilia. And the previous studies have been on initially the most high-risk group, which were the hemophilia A patients with inhibitors. Subsequently, it has also been approved for treatment in patients without inhibitors, both in the severe category where the factor level was less than 1. So this paper was in patients with mild and moderate hemophilia, who are not the first priority category usually, because it is taken for granted that they have a milder form of disease. But as we all know, we all have patients in our practice who, even though they are mild or moderate hemophilia, are either phenotypically behave as severe, or some of them, especially the older ones who are above 30, have significant joint damage and a poor quality of life, even though essentially their factor level is above 1%. And in this particularly, those with between 1 and 2%, a good number of them are phenotypically severe. So this paper focused on this population of patients who, in spite of having non-severe hemophilia, experience significant joint bleeds and other severe bleeds, leading to pain and poor quality of life. And this HAVEN-6 study evaluated the safety, efficacy, the PK and PD of emicizumab in these subset of patients. And this is an interim analysis after about 50 patients completed about 24 weeks or withdrew. So the key inclusion criteria is basically mild and moderate hemophilia without inhibitors. And a good number of them were on prophylaxis. And the other thing is this included all age groups. So the initial studies were on those who are about 12, and here it is all age groups. There were about 72 patients, and the primary endpoint was safety. And some of the secondary endpoints included annual bleeding rates, the joint health score, and a questionnaire, which is the latest questionnaire on the quality of life, which has been prepared, known as CATCH. That is the compendium assessment tool of challenges in hemophilia, was administered after about 27 weeks of treatment. That was also, the inputs from that questionnaire was also analyzed, and some other secondary endpoints like PK, PD, and immunogenicity was studied. And majority were moderate, 51, and 20 were mild. And it included both patients on prophylaxis and episodic treatment. And about a third of the patients had target joints. The indication was on for prophylaxis was as determined by the investigator, and most of them were, it was because of symptoms. So this study has shown that there was hardly any serious adverse events, and no thromboembolic event, no thrombotic microangiopathy, or any anaphylactic reactions. Only one patient had more than grade 2 serious adverse event, and even that was not proven to be emicizumab related. And the commonest symptom was adverse event was headache, followed by local site reactions. So emicizumab proved to be very safe and efficacious in the interim analysis of this study. And there was a very good reduction in the annual bleed rate, and the median value was almost 0. And the overall ABR for all treated bleeds was 0.7. And for the joint bleed, it was very good. It was hardly just 0.3. So it was emicizumab had a very good effect on all kinds of bleeding events, and about 80% of the participant had 0 bleed rate for all treated bleeds. And for the joint bleeds, it was really good, and the more than 90% had 0 bleeds. And for the overall bleeds, it was 46.5%. So one of the concerns with emicizumab is the risk of development of anti-emicizumab antibodies. So even this was not much significant in this population, and the PK was very good, and the mean emicizumab trough concentrations was even 10 to 15% higher. However, based on the PK model, this was not significant. And the questionnaire, which was administered for all the eligible patients about 12, the CATCH questionnaire, it showed a very good response across all bleeding events and across all categories, which was the quality of life, the school and work absenteeism, the pain and bleeding score, and the social activity level, and the preoccupation with disease, etc. Across all categories, the participant reported very good response. And the questionnaire was administered to about 50% participants who were eligible, and most of them preferred the emicizumab compared to the previous treatment. Only one felt the frequency of treatment on demand was much lower and preferred the old treatment. And the joint health scores improved from about 6 to 1.77, which was a very significant improvement. So to conclude, the emicizumab has shown very good response even in mild and moderate hemophilia, with no concern or no new safety signals, and no thrombotic or thrombotic microangiopathic events were reported. And this efficacy was seen across all bleeding points. So this is one of now emicizumab has shown a good profile and efficacy even in patients with mild and moderate hemophilia, thereby and has also reduced the treatment burden compared to the previous treatment regimes. Thank you.
Thank you, Meera, for that update on hemophilia A, specifically with emicizumab. So what is your experience, Meera, here on the usage of this among our patients here?
Yeah, so we have used emicizumab. Initially, we started for those with inhibitors, and it was the results were really remarkable and gratifying. Those who are bleeding and coming to us every week, and the kind of the disease burden, the bleeding frequency, and the bypassing agent usage which was given to them was phenomenal, and it was draining the resources, it was draining them. After starting emicizumab, it was almost like, in fact, some of the patients have gone about telling that their hemophilia is cured. It is, which is actually, sometimes that extent of confidence is also not good, but that is the extent to which the results this product has shown and has really changed their life and lifestyle. So, and we have also used it on some of the patients without inhibitors who are bleeding a lot. And even there, it has shown very good improvement. In fact, we have given it to one patient with pelvic pseudotumor, And it is almost the size has halved with hardly any other treatment modality, only emicizumab. And in the past, he was our desperation. We didn't know what to do with him. So the results are really remarkable.
Okay, okay. Right. Any other questions for Dr. Meera?
Any experience as a perioperative usage? Are there indications? Can we do that?
Perioperative, we have done a few minor surgeries. So for minor surgeries, just emicizumab itself is sufficient. Only the factors were on standby. For major surgeries, we have still not attempted any major surgery with, just emicizumab backup. But in the coming year, we have planned that also.
Thank you.
So, sorry, Dr. Meera. I mean, how it's available in your hospital as?
Pardon, I can't hear you.
Sorry, can you hear me now?
Yeah, yeah.
Is it available as a compassionate basis, or is it available as from the government?
It will be available from the government shortly. Right now, it is on compassionate basis.
Okay.
Okay, right. Thank you, Dr. Meera, for that update. We will now move on to the next talk, and I'll invite the chairperson for that session on myeloproliferative neoplasms. I'd like to invite Dr. Mahesh Rajsekharaya, who's again known to all of us. He's currently head and chief consultant hematologist and BMT physician at Sparsh Hospital, Bangalore. Mahesh, all yours.
Thank you, Rosh, for keeping me as a chairperson for this very important topic, myeloproliferative neoplasm, new treatment options. And more so interesting is that I'm introducing my very best friend, Dr. Mallikarjun Kalashetty. I worked as a colleague as well as a junior in KM Hospital. He's sweetly called as Malli, and now is a consultant hematologist at Manipal Hospital. And of course, everybody has felt difficult times while treating myeloproliferative neoplasms, especially when challenged with a very high platelet count or when challenged with the refractory cases. I think Malli will throw a lot of light when it comes to newer treatment options in treating myeloproliferative neoplasms. Over to you, Malli.
Thank you, Dr. Mahesh. Thank you, Sharad sir, for conceiving and making this meeting possible. Can I? Yes. And the team of Roche for putting together this. So I hope I'm audible and my slides are visible, Mahesh.
Yes, yes.
Yes. So MPN new directions is the topic, but I'm afraid I may not be taking all of you into a new direction, but perhaps take you to more of old travel road. There are plenty of slides, so I'll go through and then perhaps pause at the ones where we need to discuss. So we all know how World Health Organization has kind of classified the myeloproliferative neoplasm. The brief for today is to talk about myeloproliferative neoplasms only. And then when we talk about MPNs, we talk about Philadelphia positive and Philadelphia negative MPNs. And today we'll be talking about classical Philadelphia negative MPNs, the primary myelofibrosis, polycythemia, and essential thrombocythemia. We all know the driver mutation burden in all of these. Most of polycythemia patients would be JAK2 positive, and almost half the patients of essential thrombocythemia and myelofibrosis will also be JAK2 positive, and majority of the remaining would have some other driving clonal mutation. So myelofibrosis, we essentially diagnose based on the marrow morphology and histology, and also document the fibrosis. We also have to document the clonal mutation, which is at least JAK2 in 50% of the patients. And what we must make sure that they are Philadelphia negative and that we are not dealing with secondary myelofibrosis. There are various prognostic scoring systems that have come, but most of us in clinic continue to use IPS, DIPS, and DIPS Plus, which helps us in classifying these patients into low, intermediate 1 and 2 and high risk groups, and which is very important for making therapeutic decisions, including the timing of offering allograft for these patients. And we also know the importance of both driver mutations. We know triple negative patients would fare much inferior compared to those who have isolated CALA positivity, and also high risk non-driver somatic mutations like ASXL, IDH, and EZH2 would need high risk, would categorize them as high risk disease. So mutation enhanced scoring system is something that people are using more and more because of the NGS panel being available. And GIPS essentially uses karyotype, driver mutation, and high-risk somatic mutation. So that is how we prognosticate them. There are a few studies of prognosticating secondary myelofibrosis post PV and ET, and that also will help us in stratifying this group of patients. So most of patients of myelofibrosis have symptom burden, and most of the treatment in myelofibrosis thus far is based on the symptom that the patient has. Low-risk patients who are isolated cytopenia, we treat them to improve the cytopenia and improve the quality of life. We also will go through a few studies of ruxolitinib, and patients who have high-risk molecular signature or high-risk disease by other scoring systems must be offered a transplant. So that is a question that we always debate. So even with the advent of novel therapies, what is the role of transplantation and when and who should be offered? So what is becoming quite evident is those patients who have a high-risk disease with an expected survival less than 5 years, if they have an available donor and if they are fit enough, must proceed for an allograft. Waiting too late in the day and waiting for them to have a post-PV or post-ET myelofibrosis or leukemia transformation perhaps is not the best of idea. So high-risk disease, available donor, perhaps proceed with transplantation, knowing, making sure that the patient and families understand the risk and benefits and the short-term risks of transplant, and the aim being a long-term cure. On the contrary, if there are no donor available or if the patient doesn't have high-risk disease, then we'll treat them based on symptom-driven treatment. So ruxolitinib, I think both COMFORT-I and COMFORT-II, wherein the ruxolitinib was compared against placebo or against best available therapy, have established ruxolitinib to be a major player in the treatment of myelofibrosis, and both in terms of spleen reduction and also improving in the constitutional symptoms, ruxolitinib scores well. Even when in COMFORT-II, the crossover was allowed, the ruxolitinib patients did much better compared to best available treatment. And also what is evident is, though ruxolitinib may temporarily increase the transfusion requiring anemia, or anemia may worsen, the benefit of ruxolitinib even in these patients is quite evident. So anemia should neither be a contraindication nor its development should lead to interruption of treatment of ruxolitinib. In terms of rapidity of response, we know patients who have early regression of the splenomegaly do fairly better compared to those who have delayed or slow response. So, so again, what is also becoming increasingly evident is if we use ruxolitinib early in the disease course, those patients would also perhaps derive much better benefits and with fewer toxicity. So if you look at this pool data from both COMFORT-I and II, that the earlier intervention of ruxolitinib led to better outcome and fewer adverse events. So I think that is also becoming increasingly clear. So because when we started using ruxolitinib, we would always, do the thalidomide, lenalidomide, danazol, steroid, and then would keep waiting for the spleen to become really big or the patients will suffer significant constitutional symptoms. But now I guess we need not do that. So if I have to summarize, so we all know that ruxolitinib is effective regardless of the mutation status, that we must not decide about the dosage based on the severity or presence of anemia, but rather look at the platelet count. Development of anemia should not lead to stopping treatment. And we must always try and avoid abrupt interruption of the ruxolitinib. And dose should be tried and modified to reach a maximum tolerated dose. And that is how the patients will derive the maximum benefit. So this was also another topic that we would always debate. Can the ruxolitinib be given before transplant? Should it be given with conditioning? Can it be given during transplantation and post-transplant? And this was another abstract which kind of cleared some of this, that the ruxolitinib can be used pre, during, and post-transplant with no increase in unexpected toxicity. And in fact, they went on to say that the PFS and OS were better in patients who received ruxolitinib pre, during, and post-transplant. So this is another interesting presentation that I came across. So they tried to derive a prognostic model based on the dosage of the ruxolitinib, the splenic response, and the transfusion requirement in those patients of MF who were treated with ruxolitinib. And what they actually, of course, it needs more studies, but they said this RR6 model the response to ruxolitinib at 6 months model can be used to see who are the candidates who should be then taken to second-line treatment, who may not do as well with ruxolitinib, and maybe either putting them into interventional trials or maybe proceeding with transplant could be something that can be decided based on this RR6 model. Fedratinib, couple of those slides on that. We know it's a dual, it has dual activity against JAK2 and FLT3. And we have looked at Jakarta 1 and Jakarta 2 studies, and like ruxolitinib, it is also equally efficacious, if not more, even in ruxolitinib intolerant or ruxolitinib resistant patients. At least about 30 to 40% patients have rapid response with spleen regression and improvement in the constitutional symptoms. The common toxicity were indeed GI, diarrhea, vomiting, and nausea, and myelosuppression as expected. So this is in fact the second JAK2 inhibitor approved for the usage in myelofibrosis patients. Recommended initial dose is 400 milligram once a day in patients who have platelet count more than 50. So about 8 of patients in 600 odd treated developed what looked like Wernicke's encephalopathy. So now it happens to be a black box warning. Every patient who needs to be initiated on fedratinib, we must look at the thiamine level. And then if you have thiamine deficiency, we must replete them before initiating fedratinib so that the Wernicke's encephalopathy doesn't become a risk factor. So if you look at data in patients who were previously treated with ruxolitinib, again, quite impressive responses of spleen regression in these patients too. So patients with ruxolitinib resistant or ruxolitinib intolerant myelofibrosis may achieve significant clinical benefit with fedratinib, of course, with some toxicity, GI, and myelosuppression. So luspatercept has been widely used in patients with thalassemia, transfusion requiring thalassemia, and also myelodysplastic syndrome with ring sideroblast. And this abstract tried to look at whether we can do the same in anemia patients myelofibrosis patients with anemia. And as expected, there was durable activity of luspatercept in these patients of myelofibrosis who had anemia. And at least a quarter of patients had more than 12-week period of transfusion independence, and it wasn't too toxic in this group of patients. So cost is a big deterrent for our group of patients. Pacritinib was the best available therapy. It did improve the DC-related symptoms, but then had a lot of gas GI toxicity in these patients, like with most of the tyrosine kinase inhibitors. So in patients of myelofibrosis who have thrombocytopenia, including those with prior anti-JAK therapy, pacritinib twice daily was more effective than best available treatment, including ruxolitinib for reducing splenomegaly and other constitutional symptoms. A few updates on polycythemia and ET. So we know WHO has modified the diagnostic criteria. Now we look at HB more than 16.5. Like I mentioned, most of them have JAK2 driver mutation, and marrow morphology shows panmyelosis and subnormal EPO level. So this is another question that we always debate. Do we really need to do bone marrow studies for diagnosing polycythemia? At our center, if patients have subnormal EPO with JAK2 positivity, we don't do marrow studies in these patients. But perhaps what marrow might do is give us a baseline fibrosis in these patients. So we know that most of morbidity in this disease is because of cardiovascular events, which are seen in half the patients. And all of us treat these patients based on simple clinical risk stratification, wherein we divide patients into low risk and high risk. Patients who are younger than 60 have had no thrombosis would be treated with low dose aspirin and phlebotomy, whereas those patients who are older than 60 have had any vascular event would need cytoreductive therapy indeed. And most commonly, all of us use hydroxyurea. And good news is there have been various trials, but hydroxyurea seems to be at least not inferior to most other agents that we use. So we know better the hematocrit control, lesser are the cardiovascular events, and that is how it's the best way to treat them. So this is a study which compared PEG interferon versus hydroxyurea. So essentially, you looked at the CR rate at 12 months, and if you see there wasn't much difference between hydroxyurea and PEG interferon in this group of patients. So CR rates in patients with high-risk ET-PV treated with PEG interferon or hydroxyurea at 12 and 24 months were similar, which is a huge bonus because hydroxyurea is much simpler to use. PEG was associated with much higher rate of toxicity as expected, and both of them had equal modifying effect on high-risk ET and PV and low risk of thrombotic complications in both. So I think we will continue to use hydroxyurea in this group of patients. So another study comparing ropeg interferon with hydroxyurea in these patients. If you look at this graph, it appears as though initially hydroxyurea was doing better, but as the patients continued ropeg interferon, so the response are much better. So ropeg interferon minimizes the vascular events in these patients with PV or a long-term treatment without leukomogenic risk. In contrast to hydroxyurea, long-term treatment is capable of inducing deep molecular response, which is something which we may not see with hydroxyurea. So perhaps there is some clone-directed therapy with Ropec interferon, and over a period of time, some of these patients might actually achieve an operational cure. But then the price to pay in terms of toxicity and cost would be too much for most of our patients. So summarizing interferon for first-line treatment PV, we would try and choose patients who are younger and fitter, perhaps earlier in the course of the disease, and people who have massive splenomegaly may not be the best candidates. And the whole idea is maybe they have some clone-directed therapy, which is advantage, at least theoretically, against hydroxyurea. So various trials in ET comparing hydroxyurea with various other agents, but hydroxyurea is indeed at least on par or better than most of these agents. So I think this is something that we are increasingly hearing about, hydroxyurea resistant or intolerance in ET and PV, and that is where we want to see whether ruxolitinib is better for such patients. So response of ruxolitinib in patients with PV and hydroxyurea who are either resistant or intolerant to hydroxyurea, and as expected, patients who were randomized to ruxolitinib arm did better as against standard therapy. So in patients who have had inadequate response or had unacceptable toxicity to hydroxyurea, ruxolitinib was indeed superior to standard therapy in controlling hematocrit, reducing spleen volume, and of course also improving the constitutional symptoms. So I think that was expected. So ruxolitinib for the treatment of inadequately treated PV patients who did not even have splenomegaly, because most of the times we assume that most of good effects of JAK inhibition is because of regression of spleen. But even in these patients who did not have a big spleen, ruxolitinib seems to be better as against best available therapy. The other concern was whether the elderly patients would tolerate ruxolitinib in this group, and then it was indeed as effective and safe in elderly patients with polycythemia resistant to hydroxyurea. So I think this was a study which did not show superiority of ruxolitinib. So after hydroxyurea therapy and high-risk ET, ruxolitinib did not show improvement in either CR or PR compared to best available treatment, but it did improve the constitutional disease-related symptoms in this group of patients. Last, I think people ask us whether NOACs are as good as vitamin K antagonist in these patients of myeloproliferative neoplasms who had a vascular event. There are not many studies, but at least this one did not show inferiority of DOACs against vitamin K antagonists. So much simpler to use, and I think many of those are available. So in patients who have had vascular event, DOACs can be used in place of vitamin K antagonists as antithrombotic therapy in this group of patients. So I stop there. Thank you all for patient hearing, and back to you, Dr. Mahesh.
Thank you, Dr. Mallikarjun. That was very interesting. A question from the panelists, or shall I start with a question? Okay, let me start with a question. I had a 70-year-old lady who came with dry gangrene of the toes with a platelet count of around 22 lakhs. How do we go about this patient? Whether you want
if this was newly diagnosed patient, so one thing I would be wary is giving her antiplatelet agent because of the risk of acquired VWD. So what we do in patients with extreme thrombocytosis, we ask for recough to see whether it is more than 30% or less than 30%. So while we await that, we do the antithrombotic therapy with low molecular weight heparin, number one. Now, number two, for cytoreduction, we always start with hydroxyurea and perhaps with a higher dose, maybe about 2 to 3 grams per day, and then keep her under close observation and see her more frequently. So most of them would respond to hydroxyurea high doses with rapid reduction in the platelet count. And once the platelet count reduces to 10 lakhs, or once we are sure that the recough activity is good and risk of acquired VWD is much less, we can put them on low dose aspirin like we do.
So don't you feel the risk of bleeding is there with low molecular weight heparin in this patient?
No,
because this patient actually, like, we did not put her on antiplatelets. Just put her on low molecular weight.
So we don't actually. So anyone whose platelet count is more than 10 lakhs, we don't give them antiplatelet agents at all. So
but
we ask for So we give them. Yeah, we give them alternate. So we have not had bleeding complications. I would think without giving any antithrombotic therapy, the risk of thrombosis is way too high.
So she was unfortunate to have a bleeding on low molecular weight heparin in that case.
Oh yeah,
she had a massive intra-abdominal bleed. Yeah,
I see. And Dr. Sharath, sir, do you want to come in on this?
This is a dicey one, Malik. I mean, it's trouble for anybody. You've got gangrene on one side. You can't be sitting on it. I mean, the vascular people will get involved. and they'll be bugging you for starting multiple things,
Yes, sir.
because this platelet concept doesn't go across the acquired
Yes, sir.
VW also.
Yes.
So I think, to be fair, I think I would have done the same thing given low molecular weight.
Yes. Yeah.
Yeah, we actually did the same thing, but she had abdominal bleed, and also she started bleeding from the bone marrow site as well.
My God.
It was from the bone marrow site.
Yeah. Outlier, I guess we all would have done the same.
Right. So Malik, just your thoughts on, trying to, somebody who's potential for transplant. Are you aggressively pushing reduction in spleen size, pre-transplant, doing, ruxolitinib for some
Yes,
time?
sir.
What your thoughts?
So we haven't had an MF transplant in the recent past. But previously, so we were not doing this because we weren't sure. So we actually were stopping it 2 weeks before, and we have transplanted a few patients with very big spleen. And despite conditioning and engraftment and good chimerism, the spleen kept being very big for a long time. But now with this recent data, I think we'll be more emboldened to use ruxolitinib before, try and reduce the size of the spleen, and also will be more emboldened not to stop the ruxolitinib during conditioning either.
Right.
You've been doing molecular risk stratification panel for all your myelofibrosis patients, or only in a subset of patients who require transplant or young patients?
So till recently, we were doing only PCR MPN panel, but now I realize whenever patients go to anyone, rightly so, everybody asks for that NGS comprehensive leukemia panel, and invariably they'll pick ASXL1 or some other mutation. So now, as a part of initial evaluation, we have put that, but we don't. We are okay if they only do PCR MPN initially, Mahesh.
Okay. Any more questions from the panelists?
What's your thoughts about like a young female with the ET?
So
when you want to start cytoreductive therapy?
So no, Dr. Girish, we don't do it. Certainly, if the platelet count is less than 10 lakhs, we don't do myelosuppressive therapy at all. We do low dose aspirin, and then oftentimes you just have to keep talking to them. So if the platelet count is 4.5 and 5.5 and 6, and they will be very distressed and then distraught really. So my threshold is 10 lakhs. Yes, I would certainly not do cytoreductive therapy if the platelet count is less than 10 lakhs, and of course they must not have had any vascular event in the past.
A lot of people probably they want to get pregnant, and that's a big issue now. I mean, few of the patients, and to give interferon and all complications they may get it. So that's the thing. Well, kind of a counseling them is very difficult, isn't it? If they want to get pregnant.
Yes, no, I agree. So, but again, if the platelet count is less than 10 lakhs, we do low dose aspirin during pregnancy too. Dr. Eval, you're talking about patients whose platelet count is more than 10 lakhs and then want to become pregnant, is it not?
Yeah, that's the one. Like,
so
more
then,
than we
yes,
got a,
then,
yeah.
Then yes, yeah.
Dr. Sharath, I think there are some couple of questions in the chat box. If you want to pick it up now, yeah.
Okay, so there's one which is hyperplasia of hematogones is reported in bone marrow patients with MF following therapy. How do hematogones look like? We'll have to give it to one of our patch people. Nobody around there. We'll send that to you separately. We'll get Swati Pai to answer that for you, Dr. Vinayak.
Yes, sir.
Okay,
So
Malik
I guess
will be responsible for that.
Yes, sir. So morphologically it might be challenging, but I guess if they have doubt about them being blast, they would anyway run a flow cytometry and then make the distinction. Yeah.
Right. So Vinayak also had another question. What is the mode of action of bispecific? I think to our lymphoma speakers.
Yes, sir. So, I mean, in concept, bispecifics would, for example, they would bring the immune cells, say T cells, and then bridge them with the blast so that there is immune attack on those bad cells. Very trivial way of explaining it.
Yeah, basically it's the CD3 and CD20. You've got antibodies, towards both of them. So they basically bring the T cell to the CD20 positive cell. So that's the logic of the bispecific, both in myeloma and in your ALL and in lymphoma, for Dr. Vinayak who asked that. Yeah, I think we've cleared all the questions on the chat box there. Right, over to Malik for vote of thanks.
Yes,
or back to Roche.
Yes, sir. I think back to Roche, maybe first. Roche team, do you guys have anything to say?
Dr. Patil, you can go ahead.
Yeah, I think we had a wonderful discussion on this. The few of the handpicked topics from Best of ASH totally got immersed in the science. I would like to express my gratitude to all the faculty who are actively involved in this scientific discussion. And over to you, Dr. Mallikarjun, for a vote of thanks.
Yes. So first of all, I have to thank Dr. Sharad sir for conceiving the idea, for making this meeting possible, and continue to do all the work of Karnataka chapter of ISHBT. We'll try and do some bit ourselves, sir. And the faculty, Dr. Hari Menon, Dr. Girish, Dr. Mahesh, Dr. Natraj, Dr. Meera, and everyone else who logged in on this Friday evening. Thank you so much for being here and for sparing your valuable time and spreading the knowledge. And of course, the Roche team for supporting this, and then also for taking active role in doing all of this. So I guess if there are no more questions, we'll close the session. Thank you, everyone, and have a good evening.
Yeah, thank you and bye, everybody.
Yeah, thank you, doctors. Good night.
Thank you, doctors.
Thank you.